Let's do some good today. Hopefully, y'all like what we have in store. So, hey everyone, welcome back. I want to start today's episode by throwing out a few numbers at you that might completely change how we look at society. Right now, in the United States, roughly 100,000 people a year lose their lives to drug overdoses, and the vast majority of those deaths include synthetic downers like fentanyl. On top of that, over 16 million Americans misuse prescription sedatives and tranquilizers every single year. Think about that. That means that at any given second, millions of our neighbors, our coworkers, and family members are desperately trying to hit the brakes on their nervous system. And today, we're going to be talking about downers, known medically as central nervous system depressants. Now, I know some of you listening might think, well, I don't struggle with addiction. Nobody in my immediate household does. Why should I care? Well, here's why. Because downers shape the very world we walk through every day. It's the reason health insurance premiums change. It's the hidden crisis behind local homelessness. And it is straining our emergency rooms to the brink. But more than that, it matters because this is a human issue. It's a modern day epidemic of isolation and pain. And if we want to build healthier communities, workplaces, families, we have to understand what we're up against. This is Freudian Slips. This is where we break down psychology, therapy, relationships, all to give you the information you need to be emotionally healthy and relationally strong. It is me, Danny, and only me today. Ollie and I are working on a lot of things right now for the show, so we decided to do a little bit of divide and conquer this week. If you're new here, she and I are two licensed therapists out here just trying to do a little good. And while we're not your therapist and this isn't therapy, we do hope that you take something from today to help you live a little smarter. We are working very hard to support you, so it would really mean the world to us if you can support what they like, a share, a subscribe, check out our site for resources. It really means more than you know. Another quick disclaimer before we get into the heavy lifting. If you listen to the show regularly, you know we usually try and keep the academic jargon to a minimum. We like plain English. But today, you're going to be hearing me use some precise medical terms, words like GABA receptors, hyperpolarization, and homeostasis. I'm not doing this to sound smart or to flash a degree. I'm doing it because being medically accurate, I think, is the highest form of respect that we can show to a topic like this. You see, when we look under the hood at the actual biology of addiction, it forces us to realize something important. And that is that addiction is a profound neurological hijack. This goes so far beyond just making poor choices. It has absolutely nothing to do with someone not loving their family enough, and it is not a moral failing. When someone is in deep addiction, their brain chemistry has altered its survival code. They aren't choosing to destroy their life. Their biology is screaming, and they need this substance just to survive the next 5 minutes. So today, we are going to use current research to understand how people get caught in this trap, what it looks like, and how we actually help them break free. So settle in, let's keep an open mind, and let's look at the physics of slowing down. Now that we've framed how massive this issue is and why it hits home for all of us, let's peel back the layers and look at what these substances are actually doing inside our brain. To understand why these drugs have a tight grip on the human biology, we have to look at the physical architecture of our cells. Now, central nervous system depressants primarily include 3 major categories. First one is the opiates and opioids. This includes street drugs like heroin, but also medical prescriptions like fentanyl, oxycodone, and morphine. We also have the sedative-hypnotics. These are your anti-anxiety medications and sleep aids like Xanax, Valium, Klonopin, and barbiturates. And lastly, we have alcohol. Now, while we often treat alcohol like its own distinct category socially, pharmacologically, it is a definitive downer. These substances slow us down using 2 totally different biochemical pathways. To understand the first pathway, let's look at sedatives and alcohol. So benzodiazepines and alcohol target a chemical called GABA, or gamma-aminobutyric acid. Think of GABA as the brain's natural internal volume knob. So when you're stressed, your brain is blasting loud static. GABA turns that volume down so that you can rest. And when a downer enters the system, it forces the cell channels open, letting negatively charged chloride ions to flood the brain cells. In plain English, it forcefully turns the knob all the way down to 0. The cells find it incredibly hard to fire messages, and this causes muscle tension to drop and anxiety to instantly melt away. For the second pathway, let's look at opioids, because opioids operate entirely differently. They bind to mu opioid receptors, which normally handles your body's natural endorphins. So think of endorphins as your body's built-in thermostat for physical and emotional pain. When you get hurt or you face severe stress, they kick in to take the edge off. Exogenous opioids, meaning drugs that come from outside of the body, don't just turn up that thermostat, they completely blast the furnace. They block pain signals entirely and cause a massive indirect flood of dopamine, creating an intense wave of artificial warmth, safety, and euphoria. Now, it is important to understand that the human brain loves balance. Another word for this is homeostasis. To better understand this, I want you to picture what it's like to drive a car. There's a constant dance between acceleration and braking. And the faster you go, the harder it is to control the car. Now, in normal driving, you tend to take your foot off of the gas to apply the brake. Similarly, in healthy living, most are able to remove themselves from stressful situations to begin slowing down. But for some people, the stress of life seems to have turned their foot to lead and they can't seem to take their foot off the gas. This is when many will turn to substances to apply the brakes another way. On the outside, it looks like the person is calm, sleepy, chill, and are more in control. But on the inside, brain is now revving its engine and burning its tires because all downers do is apply brakes. They don't release acceleration. So when you artificially force brakes on every day with these drugs, the brain panics. It says, what the heck? There are way too many brakes being applied here. I need to fight back just to keep the person awake. So what does it do? It downregulates. It stops making its own natural GABA and begins hiding its opioid receptors. Now suddenly, the individual's baseline will shift. They no longer use the drug just for the high of it. They use it to feel normal. And if they take the drug away, the brain is left with an engine that is revving completely out of control without any built-in brakes. And that is the biological trap of chemical dependency. Now this brings us to a concept called cross-tolerance, because downers like alcohol, Xanax, and barbiturates all hang out at the exact same GABA receptor site. A tolerance to one means your brain automatically builds a tolerance for the others, meaning that if a person drinks heavily every day, they will naturally need a much higher dose of medical sedatives like Valium in order for them to work. Why does this matter? Because it creates a lethal mathematical trap. When people mix different kinds of downers, like drinking alcohol while taking a prescription painkiller or a sleeping pill, the sedative effect doesn't just add together, they multiply exponentially. The brain's automatic breathing centers get completely overwhelmed by the mixed signals, and the person can actually stop breathing. This is the number one reason why polysubstance downer use is so incredibly deadly. So, if this is the hidden chaos happening under the microscope and the danger of cross-tolerance, what does it actually look like in the real world? As clinicians, or even just as normal observant friends and family members, we need to know how to spot the difference between someone who is simply intoxicated and someone who is entering a life-threatening medical emergency. In the early or mild stages of downer use, you will see a generalized dampening of normal human functioning. Examples of this include things like behavioral shifts. You'll notice artificial euphoria, significantly lowered inhibition, slurred speech, and emotional lability, which is just a fancy way of saying that someone is laughing one second, sobbing the next. You'll also see physical slowness. You can notice things like ataxia. It's a medical word for clumsy or uncoordinated stumbling movements, or psychomotor retardation, which means that they look like they're moving and thinking in slow motion. And lastly, the eyes will tend to tell a story. If somebody is on opioids, look for meiosis, meaning that their pupils will shrink down to tiny non-reactive pinpoints. If they're on alcohol or sedatives, their pupils might look normal, but their eyes will display nystagmus, which is an involuntary rhythmic jerking when someone is trying to look far left or far right. Because downers depress the autonomic nervous system, the part of your brainstem that breathes and beats your heart automatically while you sleep, the single greatest threat to life is respiratory depression. If someone is in acute distress or actively overdosing, you will see what we call the opioid triad, which is extremely small and unresponsive pupils, unconscious, meaning that they will not wake up or respond even if you yell their name or rub your knuckles on their sternum, and their breathing will slow down to a dangerous crawl. We're talking less than 12 beats a minute, or sometimes it just stops completely. So please be on the lookout for cyanosis, which is when the lips, the fingernails, or the skin turn a bluish, pale, or ash gray color because the body is starving for oxygen. Also, listen closely for the death rattle, which is a dark, gurgling, or snoring sound that signals their airway is partially blocked or failing. This is also where harm reduction tools like naloxone come in. Narcan acts as a molecular bouncer. It has a higher affinity for opioid receptors than drugs like heroin or fentanyl do. It rushes into the brain and kicks the opioids off the receptors and instantly restores the body's ability to breathe within seconds. And this can be a literal lifesaver. Now, it's easy to think of these overdose symptoms as isolated tragedies, but when we step back and look at the sweeping demographic data, we see that downer misuse is a massive systemic issue affecting every layer of American life. When we look at data collected from major health agencies over the past 5 years, the landscape of downer use is deeply intertwined with the synthetic opioid crisis and shifting post-pandemic mental health trends. And I wanted to share a few of those insights with you. Firstly, according to recent data from the CDC and SAMHSA, synthetic opioids, I'm talking primarily fentanyl, remain the leading driver of overdose death. Overdose fatalities peaked heavily around 100,000 annually in the mid-2020s, with downers playing a massive role here. It's also worth noting that benzodiazepines are frequently co-ingested with opioids. SAMHSA reports that a significant percentage of opioid-related overdoses also involve benzos, making polysubstance downer use an incredibly lethal combination. Now, if we take a look at age, gender, and subcultures, we can find some more, hopefully sobering, facts. One is that we're noticing an adolescent shift. Right now, I'm talking about ages 12 to 17. An alarming trend in the past 5 years is the rise in accidental fentanyl poisoning around teenagers. This is mostly driven by counterfeit prescription pills like fake Xanax and Percocet, manufactured to look like real medication and bought easily via social media apps. Now, if we look at young adults to middle age, 18 to 49, this block shows the highest statistical rates of illicit opioid use and severe sedative misuse, which heavily impacts the local workforces and parenting generations. Historically, men have higher rates of illicit opioid use and overdose deaths. However, women are statistically far more likely to be prescribed sedative-hypnotics and benzodiazepines long-term, leading to high rates of medical dependency and hidden substance use disorders among women. And lastly, while downers impact every zip code, marginalized communities, rural areas, and Native American, Alaska Native populations experience disproportionately higher rates of overdose mortality due to the systemic health disparities and the lack of local treatment infrastructure. To treat this effectively in a clinical setting, we have to move away from generalizations and ground our assessment in standard diagnostics. So when people come into our care, how do we formally evaluate them? In professional therapy and psychiatry, we look at the DSM. Depending on the exact substance being used, downers fall under 3 major diagnostic umbrellas. We have opioid use disorder, sedative, hypnotic, or anxiolytic use disorder, and alcohol use disorder. To make an official diagnosis, a client must show a problematic pattern of use leading to significant impairment or distress, showing at least 2 of 11 specific criteria within a single 12-month period. That's a lot. So, for simplicity, hopefully, we can group these 11 criteria into 4 logical clusters. Cluster 1 is impaired control, which is taking the downer in large amounts over a longer period of time than originally intended, having a persistent desire or unsuccessful efforts to cut down or control use, spending a massive amount of time trying to get the drug, use it, or recover from it, and experiencing intense cravings. Cluster 2 is the social impairment, which is failing to fulfill major obligations at work, school, or home, continuing to use despite having persistent social or interpersonal problems caused or worsened by the drug, and giving up important social, occupational, or recreational activities because of the use. Cluster 3 looks at risky use, which is using the downer in situations where it is physically hazardous, like while driving or when mixing with other sedatives, and continuing use despite knowing that you have a persistent physical or psychological problem that is directly caused or worsened by the substance. In Cluster 4, we are looking at the pharmacological criteria, which is tolerance, meaning needing markedly increased doses of the downer to get the same desired effect, or finding that the same dose has noticeably diminished effects, and withdrawal, which is experiencing the characteristic painful physical withdrawal syndrome from that specific downer, or taking the drug specifically to stop withdrawal from happening. We would also want to note the severity of the disorder as mild, moderate, or severe, meaning that the client meets between 2 and 3 criteria, 4 and 5 criteria, or 6 or more of the criteria, respectively. Now, the final piece of the diagnostic puzzle, withdrawal, is the primary reason people stay trapped in this cycle. Remember our example from earlier. If you've been riding the brakes for months and suddenly rip your foot off the pedal, the engine will rev out of control. Now, let's look at why downer withdrawal is uniquely agonizing, and in some cases, a literal medical emergency. The immediate physical withdrawal timeline depends on how long the drug stays in the body, but the 2 main categories of downers look radically different. Let's start by looking at opioid withdrawal, which is a literal living nightmare. It is often described by individuals as the absolute worst flu imaginable multiplied by 10. Symptoms include severe muscle aches, runny nose, watery eyes, dilated pupils, increased abdominal cramping, vomiting, chronic diarrhea, and goosebumps, which, not so fun fact, that's actually where the phrase going cold turkey came from. Now, the bad good news is that while opioid withdrawal might feel like you're dying, it's rarely directly fatal unless severe untreated dehydration occurs. Now let's look at sedative-hypnotic and benzodiazepine withdrawal. This can be fatal. Because the brain's calming GABA system has been artificially suppressed for so long, removing the drug causes a massive unregulated flood of glutamate, which is the brain's exciting chemical. Symptoms here will include extreme rebound anxiety, severe tremors, tachycardia, high fever, vivid hallucinations, and critically, grand mal seizures. Now, the crushing fact here is people withdrawing from severe benzodiazepines or alcohol cannot safely tough it out at home. They require a medically supervised detox with a careful, gradual taper. Now, even after the acute physical symptoms clear up, which is usually 1 to 2 weeks, the individual faces a long, grueling stretch known as pause, and often comes with the experience of anhedonia, which is the biological inability to feel natural pleasure because the brain's dopamine pathways are slowly and painfully repairing themselves. These people can also experience neurological disruptions like chronic insomnia, severe rebound anxiety, emotional hyperreactivity, and executive dysfunction. So recognizing pause is vital for long-term recovery. We have to teach people and their families that during this phase, the brain isn't permanently broken. It's actively healing, but healing takes time. So knowing the immense biological and psychological hurdles these people face, how do we actually treat it? True recovery cannot happen in a vacuum. Effective treatment must operate simultaneously on an individual level, a pharmacological level, and a systemic family level. On the individual counseling level, motivational interviewing still seems to be our absolute gold standard. Instead of confronting the client or telling them what to do, which will just trigger immediate defensiveness, we use the core spirit of MI, which is partnership, acceptance, compassion, and evocation. We also are taught to use ORS skills to roll with resistance and to help them connect their own deepest values to the goal of recovery. And then there's also pharmacological support. For opioid use disorders, individual therapy is exponentially more effective when paired with medication-assisted treatment. Medications like methadone or buprenorphine stabilize the brain's receptors, satisfying the chemical craving and preventing severe physical withdrawal without causing the high. But we cannot treat the individual in isolation. Substance use disorder is fundamentally a family disease. You see, the family system naturally adapts to the downer use to maintain structural stability, often forcing members into rigid, unhealthy survival roles. Roles like the enabler and facilitator, which is the person who consistently protects the individual from the real-world consequences of their use, often out of deep love, but resulting in prolonging the cycle. You also have the hero, who is typically the overachieving child who tries to bring success and pride to a broken system to mask the pain. And we also have the scapegoat, the family member who acts out or creates trouble, unconsciously drawing attention away from the core substance issue. So family therapy models like family systems therapy or community reinforcement and family training approaches are vital. Craft teaches family members how to safely step out of the enabler role, allow for natural consequence to occur, and positively reinforce behaviors associated with recovery. Before we wrap up the treatment section, I want to plug in a vital piece of literature that I believe belongs on everyone's bookshelf. Now, whether you're a student, a clinician, or just someone who wants to understand the modern world, the book is called Buzzed. Straight facts about most used and abused drugs, from alcohol to ecstasy. This one, I actually have to give all the credit to Ollie, because she actually is the one who turned me onto this book. What makes Buzzed so essential is that it strips away all the political bias, moral lecturing, and terrifying hyperbole. It gives you clear, objective, and deeply fascinating science of how drugs interact with the human anatomy. It is incredibly accessible, beautifully written, and acts as a definitive cheat sheet for understanding how psychoactive substances function. So if you want a resource that bridges the gap between complex pharmacology and real-world understanding, add this one to your cart immediately, and please use our affiliate link when doing so. As we wrap up today's episode, remember, working with an individual struggling with downers requires an immense amount of clinical empathy and a rock-solid grip on medical safety. Whether it's understanding the terrifying reality of benzodiazepine withdrawal seizures or navigating a family's complex codependency, our job is to provide a safe space for stabilization and change. By working together, I mean all of us, professionals, friends, families. We can help people step off the brakes safely and learn how to navigate life's speed limits on their own terms. Before we sign off today, I also want to take a moment and speak directly to anyone listening who felt a personal tug during this episode. So if you or someone you love is currently caught in the cycle of addiction, please know this: you're not alone. And reaching out for help is not a sign of weakness. It is an act of profound courage. We truly hope that this deep dive into the science and realities of depressants was helpful, illuminating, and perhaps give you a new perspective on the struggle. Now, if this episode opened your eyes, helped you reframe addiction, or gave you tools for your own practice, please take 5 seconds to like, share, and subscribe to the show. Sharing the episode with a classmate, colleague, anyone who you think might need to hear this will help us fight stigma surrounding addiction and get the vital science into the hands of the people who need it the most. Thank you all for tuning in. Keep doing the work, stay safe out there, and we will catch you next week.